main method of action as dopamine receptor antagonists. Their aim target for the antipsychotic activity is in the mesolimbic pathway, but the extrapyramidal side effects come from their antidopaminergic activity in the nigrostriatal pathway. We can group the side effects in when they will occur after starting the antipsychotic in a patient. For example, if a patient has been on the antipsychotic for days to weeks, they could present with akathisia, an inner feeling of restlessness, or they could also present with an acute dystonia, sustained contraction of a muscle, typically affecting the eye muscles, jaw muscles, or neck muscles. Weeks to months after starting the antipsychotic, the patient may develop Parkinsonism with the triad of rigidity, bradykinesia, and a resting tremor. And after several years of being on a high dose of a typical antipsychotic, the patient may develop the severe side effects of tardive dyskinesia, a very distinctive, permanent and repetitive movements of the facial muscles. The reversal agent of antipsychotic extrapyramidal side effects is procyclidine, an anticholinergic drug. A murmur can be defined as a sound heard on auscultation that signifies an abnormal blood flow through the heart. In adults, it's nearly always a pathological sign. When we think about the location, an aortic valve murmur will be heard best over the aortic area, as signified in the diagram. And a mitral valve murmur will also be heard best over the mitral area, as again signified by the diagram. And then we can think about, is the murmur systolic or diastolic? A systolic murmur will tend to indicate either aortic stenosis or mitral regurgitation, depending on where the location is of the murmur that you've just heard. A diastolic murmur can signify aortic regurgitation or mitral stenosis. And then we can also think about the murmur characteristics, which again help to differentiate what exactly is the pathology behind the murmur. An ejection systolic murmur is associated with aortic stenosis. A pansystolic murmur is associated with mitral regurgitation. And an early diastolic murmur is associated with aortic regurgitation, and a mid to late diastolic murmur is associated with mitral stenosis.
So hi, my name is Eamon. I'm a final year medicine at University of Exeter, and I'm joined by Vabi, who's going to be helping me co-host this event. So I'm the SDOTS community manager, and we're just going to be talking about pediatric UTIs with Connor, as well as how climate change affects disease with Rafaela. Vabi, would you like to talk about yourself a little bit?
Yes. I'm Vabi. I'm a fourth year medical student at the University of Birmingham, and I'm Director of Communications for We Are Medics. So check out what we do on Instagram. It's literally at We Are Medics. That's me really in a nutshell.
Yeah, and remember to join the SDOTS Slack, join the SDOTS Facebook group, and like and subscribe to the Meds Academy YouTube channel to keep up to date with our episodes.
So first of all, we're going to start with Connor, who's going to talk us through the anatomy of the pediatric urinary tract system, and then the pathophysiology that's involved in a pediatric UTI.
Hello and welcome to this SDOCS tutorial on urinary tract infection in children. This webinar series will consist of an introduction, part 1 covering the anatomy and physiology of the renal tract, part 2 the presentation and investigations for urinary tract infection in children, and part 3 their management and a case study. My name is Connor. I'm a 5th year medical student with an interest in medical education and pursuing a career in surgery. I think this topic is worth covering as it's seldom covered during the normal medical curriculum. It's important in clinical practice, particularly in hospital and GP, and it's a good example of the differences between adults and children. Now, before we get into UTIs in children, let's get up to speed with the basic anatomy of the renal tract. There are 2 kidneys, which form the uppermost part of the renal tract. They sit between spinal levels T12 and L3 and produce a continuous stream of urine which makes its way inferiorly. Urine from the kidneys flows directly from the kidney parenchyma into a drainage system known as the renal pelvis. This is a hollow structure and is continuous with the ureters distally. The 2 ureters pass retroperitoneally alongside the psoas major muscle to join the bladder. Urine is directed towards the bladder by contractile motions in the ureters that can be described as ureteric vermiculations. The ureters join the base of the bladder obliquely at the vesico-ureteric junction. The angle at which the ureters join the bladder produces a physiological valve that helps prevent backflow of urine during urination or when the bladder is particularly full. Finally, we have the trigone and urethra. The trigone is a smooth part of the bladder that has a unique embryological origin but doesn't have much clinical significance. The urethra is a single tube that leaves the bladder to drain urine into the outside world. It is held tightly shut by muscular sphincters in its wall and varies a lot in length between men and women. So, now we've got an idea of what the renal tract looks like, let's move on to the urinary tract infections. The first and most important thing to remember in this tutorial is that UTIs are the most common type of bacterial infection in children, and in up to 50% of cases are indicative of some sort of underlying urinary tract abnormality. There are many different ways to classify urinary tract infections, but one of the most clinically useful is to divide it based on location. An upper UTI is one involving the uppermost part of the renal tract, the kidneys and renal pelvis. This is also known as pyelonephritis. And as these are abdominal structures, symptoms are usually felt more centrally and tend to cause a greater degree of systemic upset. A lower UTI is one involving the bladder and urethra only. This is the most common type of UTI and has the least systemic effects. The third type that I'll mention here is asymptomatic bacteriuria. This is when there is evidence of bacterial infection found on urine culture or dipstick, but there are no associated symptoms. It's important to be aware of this presentation, but most patients will not need treatment for it. We won't cover this any further, but bear it in mind in clinical practice. Now, one important uniqueness in paediatrics is that as children age, their presentations and management change. One example of these changes is in the epidemiology of UTI. As boys are more likely to be born with structural abnormalities of the urinary tract, they are most likely to get UTIs when aged less than 6 months old. As children age, these structural problems become less apparent and the incidence shifts to be predominantly in girls. This is reflective of adult prevalence. By the age of 16 years, you can expect 1 in 10 girls to have developed at least one UTI and 1 in 30 boys. The risk factors for the development of UTI in children are similar to those in adults. One of the biggest and most common is simply renal stasis or poor flow. This can occur due to renal stones, obstructive disease such as phimosis, vesicoureteric reflux, or may just be familial. The pooling of urine gives more time for bacteria to replicate and avoids complete clearance of the organism, thus predisposing UTI. Next is dysfunctional elimination syndrome. This describes a group of conditions that affect the process of urination. It primarily affects children. It may present from birth, but most often it is an acquired illness. The child exhibits uncontrolled urinating due to disease of the nervous system, endocrine system, kidneys, or less often as a result of infection, tumours, or trauma. It causes urine pooling and predisposes to UTI. Constipation, although not directly related to the urinary tract, can predispose UTI due to the close proximity between bowel and bladder. Significant constipation can impair voiding and must be asked about when you're taking a history. Fortunately, uncommon, but still important to bear in mind, is child sexual abuse. This can predispose UTI by structural damage or direct introduction of pathogens. If there are accompanying safeguarding concerns, don't rule it out as a possible cause of the UTI. Finally, not surprisingly, confirmed or suggested previous UTIs increase the likelihood of recurrent UTIs developing. With all this, it is important to remember that, although all these conditions predispose UTI, the majority of cases actually have no underlying risk factors. Now, I've mentioned vesicoureteric reflux as a risk factor for UTIs in children. Let's take a closer look at that. It is typically a familial disorder which causes the ureters to enter directly into the bladder rather than at an angle. This means the physiological valve that exists in normal people is not present, allowing urine to reflux backwards while the bladder pressures are high. It ranges from mild reflux into the ureter during voiding to severe reflux that causes the ureters to become dilated and possibly even flow back into the kidneys. If this occurs, the kidneys can become scarred during infection, eventually impairing renal function. Now, this is problematic for 2 key reasons. The first is that the poor outflow of urine leads to stasis, and the higher chance of infection. And the second is that backflow of the urine can easily then turn a relatively safe lower UTI into a more severe upper UTI, complicating management. Vesicoureteric reflux tends to resolve with age, but must be monitored carefully in children due to the chance of developing kidney disease later in life. Now, let's take a quick look at the causative pathogens. We won't dwell much here, but they're worth being aware of. The first thing to note is that the most common pathogens come from the bowel, although in very young children the organism can come via a hematogenous route from the blood. However, overall, the most common pathogens are E. coli, followed by Klebsiella. Next is Proteus, which is more common in boys due to its presence under the prepuce. Then we have Pseudomonas, which may indicate some underlying structural abnormality. And finally, we have Streptococcus faecalis, a common bowel organism. So that concludes part 1 of this presentation. Before we take a break, let's run through some quick multiple choice questions as a recap. What structures does an upper UTI involve? The kidneys and renal pelvis. Question 2. Why are boys more likely to get UTIs below 6 months of age? They are more likely to present with structural abnormalities of the renal tract. Question 3. Name some causes of dysfunctional elimination syndrome. Neurological disorders, endocrine disorders, infection, tumours and trauma. Question 4. Why is vesicoureteric reflux important to consider in childhood UTI? Pooling of urine increases the chance of infection, and reflux means it can track back up into the kidneys. And question 5. What are the 2 most common pathogens in UTI in children? E. coli and Klebsiella.
So thank you so much, Connor. I felt I learned so much about anatomy and the pathophysiology of pediatric UTIs, and I'm sure Babby learned quite a bit as well.
I actually really like anatomy, so that was quite good fun. Can you say fun when it's learning anatomy? But yeah, that was great. Thank you.
And now we'll be going on to the presentation and investigation of pediatric UTIs. So I'm looking forward to it. I'm sure Babby's looking forward to it. So I think you should be too.
Yes.
Welcome back to part 2 of this SDocs tutorial on urinary tract infection in children. My name's Connor and I'm a 5th year medical student from the University of Birmingham. In part 1 of this tutorial, we covered the anatomy and pathophysiology of disease in children. Now we're going to be covering the presentation and management. So, as with a lot of paediatrics, the actual presentation of urinary tract infection in children varies depending on the age of the patient. Younger children, below 3 months old, are likely to present with non-specific signs of illness related only indirectly to the UTI. These most frequently include fever, lethargy, irritability, and vomiting. Less commonly, children may have poor feeding. Relatively uncommon presentations of these younger children are pain in the abdomen, jaundice, hematuria, and offensive smelly urine. You'll note from this that it's very hard to clinch a diagnosis of UTI in smaller children based off of history alone. For this reason, you must maintain a high degree of suspicion and have a low threshold for examination and investigations. From 3 months of age, children begin to develop more urinary specific symptoms that may aid in diagnosis. The most common symptoms are frequency of passing urine, dysuria, and fever. Children may also experience generalized abdominal or loin pain, vomiting, and poor feeding. Uncommon presentations are lethargy, irritability, hematuria, and offensive smelling urine. By 3 years of age, children begin to present with the classic triad of frequency, dysuria, and suprapubic or abdominal or lumbar pain. They may also have changes to continence, fever, malaise, vomiting, hematuria, and offensive urine. Once you've got an appropriate picture for how the patient is presenting, it's time to examine them. By far the most important bedside finding to aid diagnosis is temperature. As we'll see shortly, temperature, and thus the presence or absence of fever, is essential to classify the infection. Next, examine the patient's lymph nodes and throat. Examine their abdomen for signs of hydronephrosis, such as palpable kidneys, which may indicate significant vesico-ureteric reflux, and the presence of constipation in small children. Make sure you examine their back for evidence of spinal pathology, such as spina bifida, which may cause dysfunctional elimination. Finally, examine the genitals for possible causes of obstruction, such as phimosis or adhesions around the urethral opening. While you're there, check for signs of concurrent associated infection, such as vulvitis and epididymoorchitis. So, as I mentioned, temperature plays a key role in clinching the diagnosis. The presence of bacteria in the urine and a temperature of 38 degrees or greater, or tenderness in the loins, should indicate upper UTI or pyelonephritis. Conversely, bacteria in the urine without systemic features, but still some symptoms related to the urine, indicates the likely diagnosis of a lower UTI. The specific investigations that you carry out will also depend on the age of the patient. NICE recommends that children younger than 3 months with a suspected UTI should be referred to a paediatrician and have a urine sample taken and sent for urgent microscopy and culture. Children between 3 months and 3 years should have dipstick testing first. If leukocyte esterase and nitrates are negative, do not send urine for culture and do not start antibiotics. If leukocyte esterase or nitrates are positive, then send a urine sample off and start antibiotics. For children over 3 years old, always start with a dipstick urine test. If both leukocyte esterase and nitrates are positive, start antibiotics and consider a urine culture if the child is at higher risk of serious illness. If leukocyte esterase is negative and nitrates are positive, start antibiotics and get a urine culture. If leukocyte esterase is positive and nitrates are negative, send urine for culture and only start antibiotics if there is a high clinical suspicion of infection. Finally, if both are negative, then explore other causes of illness. Now, I've been quite blasé about these investigations so far, but you may be thinking, and rightly so, how do I get a clean urine sample from a young child? This is a good question to ask. For the results of the dipstick and urine culture to be accurate, the urine must be fresh, clean, and uncontaminated. In older, toilet-trained children, this may be relatively simple and can be done as per an adult, but things get more complicated in children of a younger developmental age. The least invasive method to get a clean catch of urine from a young child is known as the quick wee method, and is as follows. Step 1, clean around the child's genitals. Step 2, place the child on the parent's lap. Step 3, hold a sterile foil underneath them. Step 4, offer oral fluids and gently rub their tummy with cold, salty water. Step 3, await the urine. Now, this can take a little while, but 30% of children should have produced a sample within 5 minutes. If it is not possible to obtain a urine sample this way, other options do exist. These include a clean collection bag attached directly to the genitalia, urine collection pads, and a catheter or suprapubic aspirate. The indications for further investigations vary considerably depending on the age of the patient, their level of illness, and the time following the acute infection. I advise, if you're curious, that you visit the link I've attached here to the Patient UK website for childhood UTI. It also contains a lot of other information that I've discussed during this tutorial. Broadly, there are 3 main investigations you may consider when assessing UTI in children. The first is simple abdominal and pelvic ultrasound scanning. This can assess the size of the kidneys, identify any congenital abnormalities, stones, and hydronephrosis. It will, however, struggle to assess the vesico-ureteric reflux to any great degree. Next is a micturating cystography. This is a fluoroscopic study of the bladder, in which contrast is introduced by a catheter. It is excellent for assessing reflux and is the only test that looks at the urethra. However, it is complex and requires a skilled radiologist. Finally, we have a technique known as DMSA scintigraphy. This uses the radiopharmaceutical technetium to evaluate the renal structure and morphology. It's the gold standard for assessing renal parenchymal defects. Right, so that concludes the content for part 2 of this presentation. Before we take a quick break, let's recap what we've covered with a few quick questions. Question 1. A child is presenting with a suspected UTI whose symptoms include vomiting. What is likely to be the age of the patient? Less than 3 months old. Question 2. What are the most common presenting features of a 4-year-old child with a UTI? Frequency, dysuria, and suprapubic, abdominal or loin pain. Question 3. What features would make you suspicious that the patient has an upper UTI? Bacteriuria and a temperature of greater than 38 degrees. Question 4. What tests would you perform on a child aged between 3 months and 3 years? Dipstick urine and send for culture if leukocyte esterase or nitrates are positive. And finally, question 5. What is a micturating cystography particularly useful for? The assessment of vesicoureteric reflux.
So thank you so much, Connor. I feel I learned a lot about the presentations and investigations of pediatric UTI. Now we'll be learning a bit about management of pediatric UTI. What do you think about that, Babby?
Well, for anyone who was watching the chats that me and Eamon had before, I actually am now starting a job in an emergency department in a pediatric hospital. So I'm really looking forward to seeing the management side of things, because I think I'll be using the information that we just learned about presentation and investigations, but the management will probably be the people much, much more above me. But it's good to have that in the back of your head, so I'm really looking forward to seeing that.
Yeah, so definitely keep on watching, guys, and also remember to join the Meds Academy Slack, the SDocs Facebook page, as well as the Meds Academy YouTube channel. Thanks, guys.
Welcome back to the third and final part of this SDocs tutorial on urinary tract infection in children. My name's Connor and I'm a 5th year medical student. In the first part of this presentation, we covered the anatomy and pathophysiology of UTI in kids. In the second part, we talked through the presentation and appropriate investigations. And now in this third and final part, we'll cover the management and look at a case study to help consolidate our knowledge. So the general management principles for urinary tract infection in children are relatively simple and not surprising. First, you should ensure proper hydration is maintained in the form of oral fluids and IV fluids if necessary. Next, encourage normal voiding, which should be as full as possible to assist with clearance of the pathogen. Finally, make sure that the treatment of the UTI is accompanied by treatment of any underlying causes such as constipation, phimosis, or renal stones. There's no point clearing the UTI if it's just going to come back right away. The more specific infection management will usually involve antibiotics to clear the infective organism. If the child is very unwell and has got underlying comorbidities that mean they are considered high risk or are under 3 months of age, you must consider immediate referral to secondary care, where there will be more support measures in place in case the child deteriorates. If there are signs of an upper UTI and the child is over 3 months old, you must also consider referral to secondary care, although it won't be on such an urgent basis. The definitive management will be with 7 to 10 days of oral antibiotics if the child is able to tolerate them. Finally, if there is a lower UTI and the child is over the age of 3 months, secondary care referral is usually not necessary. Instead, they can often be treated in the community using a 3-day course of oral antibiotics. As for the antibiotics to use, the first principle is to follow local guidance and adapt your specific choice to the sensitivities and resistances identified on urine analysis. However, the typical first-line treatment for an upper UTI is with coamoxiclav, followed by cefixime, second line, if the first cannot be tolerated or has no effect. For a typical lower UTI, first-line treatment is with an antibiotic with high urinary clearance, such as trimethoprim or nitrofurantoin. If this is unsuccessful, you can consider cephalexin second line. Although usually easy enough to treat, UTIs may recur in these young patients. Risk factors to be aware of that increase the chance of recurrence include being aged less than 6 months old at diagnosis, being female, vesicoureteric reflux, dysfunctional voiding syndrome, and other conditions that increase the risk of developing UTI in the first place. Complications, although rare, include renal scarring, chronic kidney disease, hypertension, and a possible increased risk of developing preeclampsia or hypertension during pregnancy later in life. So finally, to help consolidate some of our knowledge, let's look at a clinical case. This is Katie. She's 2.5 months old and is presenting to your GP practice. Her mother says she's had a few days' history of lethargy, vomiting and irritability, and hasn't been urinating very much despite adequate fluids. What would be your first steps in management? Katie's temperature comes back as 38.5 degrees centigrade, which is high. Her lymph nodes, back and genitals are normal. However, on palpation her abdomen feels hard and is suspicious of constipation. On questioning, her mother admits Katie hasn't had a poo in the last 3 days either. What would be your next step? Given her high temperature, age and other symptoms, Katie is referred to the local hospital. The paediatrician collects a urine sample that comes back showing E. coli infection. What should happen next? Katie is given a laxative to help with her constipation, and her mother is given advice about feeding. Additionally, Katie is given a 7-day course of coamoxiclav. By the end of treatment, Katie recovers well and has no further upset. That concludes this SDocs tutorial on urinary tract infection in children. I hope you enjoyed.
Thank you so much, Connor. I feel like I learned so much about pediatric UTIs. Now we'll be going on to Rafaela, who's going to teach us about how climate change affects our health. Thoughts, Babi?
So it's not something that I've actually thought. Those are the two areas that are really important, I think, to everyone. But I've never put them together. So I'm really looking forward to seeing how they fit, because climate change is obviously such an important thing, and it's happening right now, and it needs to change. And healthcare, everyone hopefully who's watching this video has some form of passion in healthcare or is doing something related to healthcare. So I think it's two topics that just have to be fused together, but I'm really excited to learn about it.
Yeah, so am I, and so should all of you. So now I'd like to introduce Rafaela and her awesome talk.
So welcome everyone. My name is Raffaella Melilli and I am a 5th-year medical student at the University of Exeter. Today I will deliver a webinar series on the health effects of climate change, and this was developed as part of the Medics Academy virtual elective. So why is it important to know about climate change? Now, climate change is a global challenge that can have massive implications for global health. And we have learned from COVID that environmental factors can have huge implications on health and society. So awareness of climate change and its health effects is important for medical students and doctors in order to be better prepared to face some of the global challenges of the future. So this webinar series is divided in 3 parts. In part 1, we will cover an introduction to climate change and the health consequences of the warming climate. In part 2, we will cover the health consequences of air pollution and infectious diseases. And finally, in part 3, we will cover the nutritional changes and some principles of climate change policies. So for now, we will focus on part 1. So some key facts to get started. The overall health effects of climate change are overwhelmingly negative. Climate change tends to affect the social and environmental determinants of health. So for example, the quality of air, access to safe drinking water, food security, and shelter. It is estimated that climate change will cause 250,000 deaths per year between 2030 and 2050 from things such as malnutrition, malaria, diarrhea, and heat stress. And the areas with weak health infrastructures, so mostly developing countries, will be the less able to cope with these changes without any assistance. So finally, reducing emissions of greenhouse gases through better transport, food and energy use choices results in benefits not only for the environment, but also in improved health, as we will see. So when we think about climate change, there are 4 main primary elements that cause the health effects we see. These include higher temperatures, higher atmospheric CO2, sea level rise, and floods and droughts. And this can cause direct health effects or exacerbate existing medical problems. So when we talk about global warming, we are talking about the global average temperature. And this has increased by approximately 1 degree Celsius since the end of the 19th century. And it is likely to increase by at least 2 degrees Celsius by the end of this century. And one key thing to notice is that when global temperature rises, this does not happen equally everywhere. So places like the northern parts of the planet, as well as parts of Brazil and Australia, are warming many times faster than the tropics. The underlying process that drives global warming is the greenhouse effect. So this means that there are gases in the atmosphere which trap heat, and in so doing, they allow the heat energy coming from the sun to not be lost in space, but to remain in the atmosphere. And this is what makes the climate on the planet what it is. Some of the most important greenhouse gases are carbon dioxide, methane, and nitrous oxide. And CO2 among all of these is the most common greenhouse gas by volume. We know there is a strong correlation between CO2 and temperature because of the greenhouse effect. And as CO2 increases, temperature also increases. So we also know that increases in CO2 levels have been associated with increases in global average temperature, leading to a climatic shift towards hotter weather and more records of hot weather. And this occurs because as concentrations of CO2 and other greenhouse gases increase in the atmosphere, because of the greenhouse effect, the amount of solar radiation that gets trapped also increases, and then there is an increase in global temperature. So it makes sense to expect that adding greenhouse gases into the atmosphere in the future will warm the planet even more. There are several factors contributing to the overall surface temperature, and you can see from this plot that greenhouse gas derived from human activities is the main contributor to global warming, while other factors are substantially negligible. And most of CO2 emissions are generated by burning fossil fuels, such as coal, natural gas, and oil. As for sea level rise, there has already been a rise of 90 millimeters since the early 1990s, and it is expected that the rise will be at least 1 meter and perhaps 2 meters by the end of the century. And this is relevant because 1/3 of the world's population, so that's about 2.4 billion people, lives on a coastal region, and many of the world's largest cities are located on the coast. The two main causes of sea level rise are melting of land ice, firstly, particularly in Greenland and Antarctica, and secondly, thermal water expansion. Thermal expansion of water happens because more than 90% of the atmospheric heat is absorbed in the ocean, and as water warms, it tends to expand. So again, one important thing to notice here is that rates of sea level rise is not homogeneous, it's not a homogeneous process, and some places are more affected than others. As global temperatures increase, there is also an increase in extreme weather events, both in terms of intensity and frequency. And this is because warmer air holds more water, and where that air with more moisture is ready to rain, it rains in greater amounts, potentially leading to floods and natural disasters. At the same time, warmer temperatures also cause more evaporation and drying of land, leading to desertification. So this may seem contradictory, but once again, this process is not uniform across the globe, and places that already tend to get more precipitations will get even more, tending towards floods, while places that tend to get less precipitations will get even less, tending towards droughts. So climate models suggest that rainfalls will become more intense in places like North America, Europe, and Asia. So the take-home messages so far are the 4 primary drivers that from climate change lead to health outcomes are warmer temperatures, greenhouse gases emissions, sea level rise, and extreme weather events. The largest contributor to climate change is emission of greenhouse gases from human sources, and all the climate processes we have seen are not spread homogeneously across the globe. So now we will start looking into the health outcomes of climate change in detail. And when thinking about health outcomes of climate change, it is useful to divide them in 4 groups. And this classification is not exhaustive by all means, but includes the main outcomes we'll talk about. So the first group includes health outcomes of heat, such as heat-related illness. The second group includes health outcomes associated with air pollution. The third group includes infectious diseases, which are driven by things such as rising temperatures, precipitations, and biodiversity loss. And the fourth group includes the nutritional outcomes resulting from changes in crops and fishing products. So in this first part of the webinar series, we will cover the health outcomes of increased heat. So let's start with heat and health. The amount of global population exposed to heat is increasing due to climate change, and the temperatures are increasing in frequency, intensity, and duration. So it is estimated that between the 2000 and 2016, the number of people exposed to heat waves increased by 125 million. And we know that heat waves are associated with increased mortality. If there is no substantial move from fossil fuels and the planet warms by 4 degrees Celsius in the worst case scenario, 3/4 of all people will experience lethal heat waves by the end of the century. And as global temperatures continue to increase, more people will be affected by health consequences associated with extreme heat. The heat exposure pyramid shows a range of health effects caused by heat exposure and the proportion of population that may be affected. So the wider the pyramid is at each level, the more people are likely to be affected by that specific health effect. So starting from the base, most people may experience mild symptoms such as sunburns, heat rash, heat cramps. Heat also makes it harder to think, and it is shown to decrease productivity, reducing work capacity and labor productivity. And this may be significant in developing areas of the world. Going up, there will be a proportion of the population with pre-existing disease made worse by heat, particularly heart failure, diabetes, lung disease, and renal disease. And this is because heat can promote dehydration, which can make all of these diseases worse, but also heat causes direct stress to organs such as heart and lungs, and so they start working less effectively. And then also higher temperatures raise levels of ozone and air pollution, and this further exacerbates cardiovascular and respiratory disease. As we go up, other heat-related illnesses can occur, such as heat exhaustion, heat stroke, and this can ultimately lead to death. And although death from heat is rare, these conditions are dangerous and need to be taken seriously. So as global temperatures rise, it is expected that there will be an increased incidence of heat-related consequences in certain areas. And in those areas where there is already an exposure to these effects, they may experience them with more frequency and in more severe forms. Everyone is potentially vulnerable to heat. However, this is most dangerous for certain groups, including people who live in tropical regions, outdoor workers such as farm workers, construction workers, fishers, because all of these people suffer from a substantial burden from day-to-day temperature increases, as well as the poor, displaced, and homeless. Then the extreme of age, so children and the elderly, because they have a less ability to dissipate heat effectively. And finally, people with pre-existing disease, as we have already seen. So we have discussed heat-related illnesses and exacerbation of chronic diseases, which can lead to accelerated death and increased mortality. But there are other effects of extreme heat that is worth mentioning. One of these is the hospitalizations that can occur from respiratory disease, diabetes, renal disease, stroke, and mental health conditions. And also the impact on healthcare services as extreme heat increases, because usually this is associated with increased ambulance call-outs, slower response times, more people seeking care in emergency departments, and increased number of hospital admissions. So the scale and nature of the health impacts of heat depends on the timing, intensity, duration of a temperature event, as well as the level of acclimatization, the adaptability of the local population, the infrastructure and institutions to the prevailing climate. So you can see that the picture is very complex and predictions are difficult to make. So this is the end of part 1 of this webinar series, and thank you for listening. And make sure you check out part 2 of the series, which you can find below in the description of this video.
Thanks so much, Rafaela, for the first part of your video. I feel I learned a lot about climate change and the effect it has on disease and on people, and basically on like everything regarding our lives and our like lifestyles. What do you think, Bobby?
Yeah, definitely. Like, it was quite good to almost, some of the things were like recapping knowledge that I had way back in sort of like the GCSE, like the physics and the geography side of things. So it was really good to have like a refresher, but it was very interesting to sort of put into perspective the different aspects of everyone's lives that could be affected, well, that are affected by climate change.
Yeah, I mean, I literally did environmental science way back in like ancient times, and like yeah, I just like I just never use it. Like I just like have all these facts about eutrophication and like how lakes turn green and all that, and just like never think about it again. But other than like in global warming, which is a very important fact that we should all be thinking about. Yeah. So thank you so much, Rafaela, for reminding us of everything. And now we'll be talking about air pollution with Rafaela. So look forward to that. And I hope you guys enjoy the teach, but you're definitely going to enjoy it. So, yeah.
Welcome, everyone. My name is Rafaela, and I am a fifth-year medical student at the University of Exeter. Today, I will deliver a webinar series on the health effects of climate change, and this is part 2 of the webinar series. And this was developed as part of the Medics Academy virtual elective. So in part 2, we will cover the health consequences of air pollution and infectious diseases. So let's start with air pollution. It is estimated that 91% of global population is exposed to air quality levels that exceed the WHO guideline limits. So this is about 9 in 10 people globally. And approximately 4.2 million people die from outdoor air pollution each year. Meanwhile, 3.8 million people die from indoor air pollution each year. And mortality largely results from stroke, heart disease, COPD, asthma, lung cancer, and acute respiratory infections. So one of the major contributors to outdoor air pollution is ground level ozone. And this is formed from the reaction with sunlight of pollutants such as nitrogen oxides from vehicles and industry emissions, and volatile organic compounds which are emitted by vehicles, solvents, and industry. Excessive ozone at the ground level can cause a variety of health problems, mostly due to inflammation. So for example, inhalation of ozone can cause inflammation in the lungs, and this can cause breathing problems, trigger asthma, exacerbate lung disease. And the most vulnerable individuals are people with chronic lung and heart disease. Ozone can also cause burning of eyes, nose, and throat, and headaches. Particulate matter is another important air pollutant, and this is a complex mixture of small solid and liquid particles suspended in the air. There are different types classified according to diameter of the particles, and one of the most dangerous ones is PM2.5, which means it is 2.5 microns in diameter. And this can, because it's so small, it can penetrate and lodge deep inside the lungs, entering the bloodstream. So research has shown that inhalation of particulate matter can be deadly by causing heart attacks and strokes. Also, chronic exposure can cause cardiovascular and respiratory disease and lung cancer. Particulate matter can be produced by combustion of fossil fuels, wildfires, burning domestic fuel for cooking and heating, and industrial emissions as well. So now let's move on to discuss infectious diseases. There are many infectious diseases, but we will look at malaria specifically and use it as an example to explain some of the changes that may be seen in the spread of vector-borne disease in the context of climate change. So malaria is a parasitic disease transmitted through mosquito bite. And although malaria is fatal in about 0.3% of cases, it represents a major global challenge. In fact, more than 200 million people each year contract malaria, and this is mostly in lowland tropical areas. And more than 400,000 people die, and this is mostly young children. And climate change matters to vector-borne diseases such as malaria for many reasons. First of all, insects are ectotherms, which means they're cold-blooded. So this means they're sensitive to the temperatures of their surrounding environment. So their biological processes, such as metabolic rates, development rates, reproductive rates, are all dependent on temperature. At the same time, the parasites carried by the insect vectors are also temperature sensitive, especially in the time the parasite spends developing in the mosquito. However, the relationship between temperature and malaria transmission is complex and shows many nonlinear aspects. So some of these nonlinear aspects are summarized here. Higher temperatures promote both higher mosquito biting rates and faster parasite development. However, at high temperatures, the predicted vectorial capacity, which is the rate at which mosquito bites can transmit infection, is reduced. So this means that at high temperatures, mosquitoes are less likely to transmit disease. Also, at high temperatures, there is an increase in mosquito mortality rate. So what does it all mean? Because mosquito and parasite metabolic processes are temperature dependent, warmer temperatures accelerate mosquito and parasite development, and they also accelerate malaria transmission. But then there is a point where temperature increases and becomes high enough to be lethal. So there is a sweet spot, which is the ideal temperature of malaria transmission, and it is about 25 degrees Celsius. In the future, there may be a shifting suitability for malaria. So some places, such as East Africa, that are now a little below the optimum temperature, will reach optimum temperatures for malaria transmission with global warming. Other places, such as West Africa, which are already at the optimum temperature, may become too warm, leading to a decline in malaria transmission potential. And the problem with this is that there is a big risk of large populations coming into higher risk of malaria transmission, depending on the local temperatures. And also the risk that potentially millions of people that haven't been exposed to consistent malaria risk before, or at least not at an endemic level, they are suddenly becoming exposed more and more often. So finally, keep in mind that the picture is much more complex. So other factors such as altitude, precipitation, urbanization all influence mosquito prevalence and disease transmission. And also, besides climatic factors influencing vector and parasite characteristics, there are also human factors. For example, human interventions that can be implemented to reduce vulnerability to infection. So this suggests that predicting future malarial incidents based upon effects of climate change alone may be difficult. And while climate change can create conditions that are either permissible or not permissible for disease transmission, just because you have suitable conditions, it doesn't mean you will have big outbreaks. And that is because of the economic development and vector control activities. So it is worth mentioning as well the biodiversity in the context of health and climate change, because one of the main questions at the moment is whether we should expect more pandemics in the future. Biodiversity refers to the biological variety of life on the planet in all of its forms. And biodiversity is essential for life in ways that may not be always apparent or appreciated. For example, it supports many human needs, including availability of nutrition, energy, fresh water, development of medicines, and all of these underpin good health. Climate change is contributing to biodiversity loss through things like land use change, pollution, ocean acidification, chemical and waste contamination. And long-term changes can cause shifts in the distribution of plants, pathogens, animals, and even human settlements. So biodiversity loss can have significant negative effects on human health due to the disruptions of the ecosystems that support our human needs. For instance, biodiversity loss may mean reduction in the productivity of soil or in the nutritional variety of food that is fundamental for health. Major processes such as deforestation, land use change, water management, urbanization, migration, all of these contribute to shifting in patterns of infectious diseases. Climate change may also lead to a biogeographical redistribution of species towards cooler temperatures. So as a result, we may see animal species moving into areas where humans are prevalent, and this will create a new human-animal interaction and potential opportunities for pandemics to evolve, particularly from zoonotic diseases, although these are still early days for research and predictions are difficult. And then there are also indirect effects, because indirectly changes in the ecosystem service affect livelihood, income, local migration, and of course, in some occasion, it may even cause or exacerbate political conflict. So the The main take-home messages that we have covered in part 2 are that there are many air pollutants, including ground-level ozone and particulate matter. The groups most vulnerable to air pollution include the elderly and people with chronic disease. Relationship between climate change and infectious disease is complex, but a redistribution of vector-borne disease is likely based on the local temperatures. And also, incidence of new diseases may be possible as a result of biodiversity loss. So this is the end of part 2. Thank you for listening, and make sure you check out part 3 of this webinar series, which you can find below in the description of this video.
Thanks so much, Rafaela. I feel like that was a really interesting talk. And what do you think, Babi?
Yeah, I mean, the part about the mosquitoes and malaria, it makes sense, but I never I never pieced it together because I don't know, I just never thought about malaria. But it's really interesting that, you know, you increase the temperature and a lot of the creepy crawlies come out, and the diseases that they carry with them are sort of, it is their festival, that is. So that was really interesting to see and to hear about. So I'm definitely a bit more aware of the impacts that climate change can have literally on diseases that I just didn't really put together.
Yeah, definitely. I mean, literally, as a person that comes from a hot country, like we have so many mosquitoes. Like I get bitten so much, and when you come back to England, it's just it's quite cold, which is
refreshing.
Which is different, yeah. But it's definitely it's definitely nice to not get eaten alive, literally.
Yeah, I think that sounds justifiable.
Yeah, so thank you so much, Rafaela. And now Rafaela will be telling us about nutrition and climate change. So many things about how a changing soil, nutrients, as well as global fish stocks are also decreasing due to climate change. So look forward to that, and I'm sure you guys will enjoy that so much.
Welcome everyone. My name is Rafaela and I'm a 5th-year medical student at the University of Exeter. This is part 3 of a webinar series on the health effects of climate change, which was developed as part of the Medics Academy virtual elective. In part 3, we will cover nutritional changes and principles of climate change policies. So let's talk about nutrition first. Climate change can lead to a variety of nutritional deficiencies. Some of these include macronutrients such as protein deficiency and micronutrients such as vitamins, calcium, zinc, and iron deficiencies. Protein deficiencies can lead to many issues such as kwashiorkor and birth defects. As for micronutrient deficiencies, low vitamin C causes scurvy, low calcium causes osteoporosis, low zinc can result in a variety of issues from depressed growth to skin lesions to diarrhea, and zinc deficiency also accounts for 4% of childhood deaths. Iron deficiency is the most common nutritional deficiency in the world, affecting billions of people, and it is the major cause of anemia, which contributes to 20% of maternal deaths globally. And iron deficiency anemia in young children also results in lower IQ and can impair brain development. The most vulnerable populations to nutritional deficiencies are children, and this is because inadequate caloric intake can lead to stunted growth, and highest percentages are in Africa and South Asia, but also greater susceptibility to infections and impaired brain development. Other vulnerable groups include the elderly and women of childbearing age. So what are the climatic factors that impact food supplies? Elevated carbon dioxide can have direct effects on crop yields. It changes how much crop we can grow and also substantially decreases the nutritional value of crops. Higher CO2 reduces concentrations of important nutrients like zinc, iron, and protein in grains and legumes. Extremely high temperatures can have negative effects. In fact, too much heat stress leads crop yields to drop quickly. Also, increasing temperature and humidity are incompatible with prolonged physical activity for agricultural labor. So the effect will be largest in places with the least capacity to replace agricultural labor with mechanization. Extreme weather events, such as increase in amount of precipitations, extent of individual precipitation events, Periods of droughts and flooding on land are all relevant to food production because both too much water and too little water make growing crops difficult. Salinization of fresh water due to sea level rise means that less fresh water is available for growing crops. Air pollution and ground level ozone can be toxic to plants, reducing plant growth. And finally, pests that are pathogenic to plants are more active at warmer temperatures, exposing plants to greater danger of being damaged. Another important source of nutrition besides crops is seafood, which is a source of animal proteins, particularly important in the nutrition of coastal and tropical regions. In fact, about 3 billion people get 20% of their animal protein intake from seafood, and in coastal regions, 50% of animal proteins comes from seafood. Unfortunately, global fisheries are largely in decline due to overfishing. 90% of global fisheries are fully or overexploited, meaning that given current fishing practices, they will be entirely consumed by 2050. At the same time, climate change will impact seafood nutrition in a variety of ways. Since 90% of excess heat is absorbed into the oceans, as we've seen in part 1, this added heat is making regions of the tropics too hot for the fish to live, and so the fish are migrating towards the poles. As this happens, people along the equator, which are coincidentally also the most food insecure people on the planet, will have less access to some of their traditional foods, particularly seafood. Another reason is ocean acidification due to the direct effect of CO2 dissolving in the oceans, which affects fisheries and access to seafood. In fact, more acidic oceans cause dissolution of the coral reefs, and these coral reefs serve as habitats for many fish. So as the reefs disappear, the fish lose their habitats, and this affects particularly those communities that subsist on seafood captured just offshore in the tropics. So what will be the effects of climate change on nutrition? We currently have around 800 million people in the world who don't get enough to eat on a daily basis, and around 2 billion people who suffer from micronutrient deficiencies. Due to changes in nutrition, there will be people not currently affected who will fall below the estimated average requirement for a given nutrient and become a risk of deficiency. It is estimated that 150 million people will be at new risk of protein deficiency, and effects of protein loss will be most severe in Southern and Southeast Asia. And these effects will be most pronounced for the poorest people in the country because they are least able to afford animal protein. Between 150 to 200 million people will be pushed into new risk of zinc deficiency, and greater prevalence will be in sub-Saharan Africa, Middle East, and India. As for iron, about 60% of people who are vulnerable to iron deficiency will lose 3.8% or more of their total iron intake. And again, all of these outcomes reflect changes in diet because people are consuming crops that are losing their nutritional value due to higher CO2. We may also see dietary shifts in certain populations. The many pressures on reefs and fisheries around the globe are forcing the coastal port to find alternative food sources. And among inhabitants of small island states, the next available option may be highly processed and caloric foods that are typical of the Western diets, and that is the same food that has spurred the global rise in obesity. So to conclude, we have seen that human activity is the largest contributor to climate change. And that means the human behavior is also the largest modifier of the health impacts of climate change. The three main ways through which human action can reduce the effect of climate change on health are adaptation, mitigation, and health co-benefits. So starting from adaptation, this includes those actions to protect populations from the effects of climate change that have already occurred. Mitigation includes policies to attenuate climate change, particularly reducing greenhouse gas emissions. And then health co-benefits are the health gains from climate-friendly policies and individual behavior. So particularly focusing on the health co-benefits, examples of these include shifting from fossil fuels to renewable energy, resulting in less air pollution, so less of the cardiovascular and respiratory consequences we have discussed in part 2. Shifting in diet from meat to legumes and vegetables results in less premature deaths and less colon cancer. Seeking active transport such as cycling rather than driving helps with heart disease, mental health, obesity, and diabetes. And finally, better insulated buildings means greater energy efficiency in buildings, leading to better air quality in the household. So the final take-home messages are undernutrition, nutritional deficiencies, and dietary shifts are all possible outcomes of changes in food availability. We have seen how climate change leads to drivers that, through a variety of mechanisms, result in many health implications of both individual and global significance. And finally, several interventions can be put in place which have positive effects not only on the environment, but also on human health because of the co-benefits and the coexisting relationship between the two. So thank you for listening. This lecture was a result of the Medics Academy virtual elective, which I highly recommend to any medical students who are interested in medical education. And to find out more about virtual elective and other ways to get involved with Medics Academy, check out the description box below. And for any questions, you can find both Medics Academy and myself on Twitter.
Thank you so much, Raphael and Connor. Those were awesome talks, and I definitely hope to hear from you guys at a later date or hopefully sooner in the future. And I feel like I learned a lot about climate. I learned a lot about pediatrics and urinary tract infections. Like, I literally, before I did medicine, I would have never thought a urinary tract infection would be so detrimental to health. What did you think about UTIs before like medicine? Do you think they were just like a normal thing that just kind of like went away basically and would not have any like problems?
Yeah, to be honest, I thought it was very much like oh, bless you, like that's fine. And do you know what, the thing is, I don't think we get enough pediatric exposure before medical school, obviously, but even throughout medical school. I personally am in my 4th year now. No pediatric experience, no sort of knowledge of pediatric conditions. So if you said to me how common is a UTI in a pediatric patient, or, you know, what would you think of, I would just go brain dead, to be honest with you. So that was really useful. Thank you, Connor, for that. Like, it was great to have just a little bit more confidence in that area. Maybe make a budding pediatric physician out of me, who knows. And yeah, with the climate change, like I said before, 2 very important aspects of life that I never like put together. I obviously know that, you know, climate change has these impacts geographically, and that, you know, futures to come, unsustainability of fossil fuels, all of that stuff, but I never really thought it would be bad for your health. And again, with the nutrition, overfishing, it's something that we've all known about since GCSE times because we've covered it in the syllabuses, but I didn't quite put that in with healthcare. So that was really useful to actually have someone bridge that gap for me. So again, thank you very much.
Yeah, like, you guys were awesome and amazing. So thank you so much for teaching for us. And guys, remember to join the S.Dots Facebook group, join the S.Dots Slack, and like and subscribe to the Medics Academy YouTube channel to keep up to date with our content. Any last words for everyone, Babi?
No, my brain is just so full of knowledge that I can't even think of any last words, but have a lovely day and keep learning.
Well, that's great. Thank you so much. And bye, guys. Like, join us for the next episode, and which we'll see on our S.Dots Facebook page. So join that. And yeah, thanks so much.
Bye.
Bye.
Tetralogy of Fallot is the most common cyanotic congenital heart disease. It causes severe symptoms, and the definitive treatment for it is open heart surgery, normally done before the baby is 12 months of age. Tetra means 4, so there's 4 things that go wrong in tetralogy of Fallot. I find it useful to remember it in the following order, starting with pulmonary stenosis, the complete closure of the pulmonary valve. Number 2, right ventricular hypertrophy, thickening of the right ventricular muscular wall. Number 3, a ventricular septal defects between the right ventricle and the left ventricle. And number 4, an overriding aorta where both the right ventricle and the left ventricle flow directly into the aorta. So the disease does not pathophysiologically manifest itself in this order, but hopefully it's easy to remember the structural pathology of tetralogy of Fallot in this way. IV fluid resuscitation is indicated when a patient is showing signs of clinical shock. Using your ABCDE approach, by the time you've come to see, you should have a good idea of whether the patient is in shock or not. You may see signs of hypotension, tachycardia, cool peripheries, a long capillary refill time, or a high respiratory rate. You then want to initiate treatment when you suspect clinical shock. You want to give 250 ml or 500 ml bolus of IV crystalloid given over 15 minutes. The crystalloid solution can either be Hartmann's solution or 0.9% normal saline, and it's good practice to give 250 ml if the patient has known or suspected heart or renal failure. After this, you want to reassess the patient again using ABCDE. Their signs of clinical shock may have improved at this point. However, if there's no change, continue with further boluses of IV crystalloid. If the patient has now received 4 rounds of bolus fluid and there's still no improvement, now it's time to get help. The patient needs ICU advice and